because we are going to televise this, not televise, we record this event. අපි මේකත් දෙමු පොඩ්ඩකට අර මයික්‍රොෆෝන් එක මේ සිසිර මෙහෙන්න මේ මයික්‍රොෆෝන් එක before Ivan, before commencing the proper the webinar by College of Palliative Medicine of Sri Lanka in collaboration with Minister of Health, we would like to get to know with each other because I see some new faces. And we welcome, official welcome will be done by the president, current president of the college. But before that, we would like to go for a self-introduction. I am Dr. Lakshmi Somatunga. I am the Additional Secretary, Public Health Services, Ministry of Health.
I am Dr. Samadhi Rajapaksha, President, College of Palliative Medicine of Sri Lanka.
I am Dr. Saman Gamage. I am a consultant community physician from NIHS Kalutara.
I am Dr. Angana Vadukethara, Medical Officer in Health Informatics attached to the Additional Secretary, Public Health Service Office, Ministry of Health.
I am Dr. Nimdiru Maya Kaduwa, Medical Officer, Health Informatics attached to Additional Secretary, Public Health Services Office.
I am Dr. Buddhika Mahesh. I am a council member of College of Palliative Medicine of Sri Lanka.
I am Dr. Talagala. I am medical officer from LRH and the council member of the College of General Practitioners Sri Lanka.
I am Dr. Shankar Talagala, editor of the College of Palliative Medicine Sri Lanka.
I am Pushpa Singha. I am the Vice President of the College of General Practitioners and Council Member, College of Palliative Medicine.
I am Dr. Priyanti Premaratna. I am MO LRH and also a member of a college, GP College.
I am Kalpani Vijayavardhana. I am a council member of College of General Practitioners of Sri Lanka and College of Palliative Medicine of Sri Lanka.
I am Dr. Madhusha. I am from KWH Panadura and also I am a member of the College of General Practitioners.
Eugene Correa, GP Piliandala.
I am Dr. Indik Karnamuni and I am an independent medical practitioner and I am representing College of General Practitioners today.
Thank you very much. Actually, it's very pleasing to see all of you. I think this webinar will be important for you as your health ministry official for your title in the Ministry of Health, role in the Ministry of Health as well as a GP. Thank you very much.
Now it's 11:30. Now we are going to start this important webinar. Let me welcome all of you. Good morning and very happy New Year from the College of Palliative Medicine of Sri Lanka and the Ministry of Health. Today we are going to have a hybrid webinar on improving communication and collaboration in medical certification of cause of death. So as a College of Palliative Medicine of Sri Lanka, every month we have a webinar series. So this month April webinar is little different because we have a hybrid session. So today there will be 3 speakers, Dr. Lakshmi Somatunga, our Additional Secretary, Public Health Services, Ministry of Health, and Dr. Saman Gamage, he's a consultant community physician, and Dr. Rangana Vadugedara, who is the medical officer in Health Informatics, Ministry of Health. So, and I welcome all the participations through via Zoom who are now participating in this important webinar. So first, I will invite Dr. Lakshmi Somatunga to deliver her lecture presentation on importance of proper certification of cause of death. So let me read the citation of Madam Lakshmi Somatunga. She is the present Additional Secretary, Public Health Services of Ministry of Health, Sri Lanka. Started her administrative career in 2001 as a senior medical administrator. Having obtained postgraduate qualification in public health, MSc in 1994 and doctorate in 1999, she has worked in different institutions in the health sector. Previously, she was the Director, Non-Communicable Diseases, during which she launched National Tobacco Control Program and Injury Prevention Program for the Ministry of Health. Also, she held the post of Director, Mental Health, during which she initiated promotion of mental well-being program. Her immediate previous post was Deputy Director General, Medical Services. Currently, her preview is policy and evaluation of all public health programs. She was the immediate past chairperson of Commonwealth Advisory Committee on Health for past 4 years. Dr. Somatunga has authored numerous research papers in the field of tobacco and alcohol control, injury prevention, and healthcare quality. Dr. Somatunga is a fellow of the College of Community Physicians of Sri Lanka, and she is the immediate past president of both colleges of Community Physicians and College of Palliative Medicine of Sri Lanka. Madam, over to you to present about the importance of proper certification of cause of death. Thank you.
Thank you for gracious introduction. Ayubowan, and good morning to all of you. Also going with the tradition, I wish you all a very happy new year. My topic today is importance of medical certification of cause of death. Indeed, I am really happy to be a part of this very important webinar on this important subject because I am connected in 2 ways. One, as the Additional Secretary, Public Health Services of the Ministry of Health, and 2 is, as mentioned in the citation, I was the first president of College of Palliative Medicine in this country. Why this is important? If you, when you take let me take the presentation to the okay. Right, thank you. In simple words, we must know the proper cause of death. Why? In simple terms, because I am going to talk a little bit in details later, in order to improve how people live, and also it will assess the effectiveness of our health system. saving lives by counting deaths. You know that what is civil registration? That is continuous and universal recording of occurrence and characteristics of vital events. Or, in other words, it's a system by which a government records the vital events. As you almost all of you know, the vital statistics are all the data, quantitative data concerning the population. As it is depicted here, you can see not only births, deaths, divorces, and so on, abortions. Then, the introduction proper. Reliable mortality data derived from quality cause of death is vital for evidence-based public health policy making. Deaths are not just deaths for us, especially for public health specialists. There's a story behind every death, and that is very important to us. Though Sri Lanka had achieved almost 100% death registration, because the event of death is connected to many legal happenings, even for assets, properties. Anyhow, we count deaths, almost 100%. But quality of cause of death data remains questionable in this country. Why this is important, this civil registration and vital statistics? We all are talking about SDGs or Sustainable Development Goals always. That is the world trend. Whole world is gearing towards achieving these important goals. When you take all 120 indicators, more than 1/3, which is 45 indicators, really require data from a CRVS system. That further emphasizes the importance of CRVS. As I said earlier, deaths are happening. It's a definite event. When you take our country, about 50% of deaths occur in hospitals and are certified by doctors using death declaration form. You will be exposed to this death declaration in the next presentation and gaps in the third presentation. So when we say around 50% of deaths do happen in the hospitals, that means the other part, the other 50% do happen in the community. So irrespective of the place where it happens, we health ministry, we need the quality cause of deaths. Otherwise, when we take decisions based on these deaths, we take wrong decisions. Not wrong, but very outdated. At present, the data for Sri Lanka we receive is not for the previous year, not for the one before the previous year even, 3 years back. So it is highly outdated. Another importance I want to highlight here, where are we as a country? When you take the global context, the performance regarding these vital statistics are done based on Vital Statistics Performance Index, VSPI. I think it's clearly illustrated on this map where we are. Not very low, but low. See, the happenings, at least not medium, not good, I mean high, not very high, you know. So, little better than very low. So, that is why happenings like the similar happenings like these webinars, awareness, training, capacity building are very important to take the country to the at least next level, and very simply because we are good at quantitative aspect, why not we go for qualitative aspect, quality data, and make our country in a better color here. Soon, I am confident that with the support of all stakeholders, we can achieve, better situation for our own country at the global context. What have we done? This is just one small event. We have done a lot to improve this situation. Starting with the pilot project in 25 hospitals, that is to make master trainers on this training of trainers on proper declaration of cause of death. Then I will be talking about it a little later. Handbook for Sri Lankan doctors on cause of death certification. Today it is available. Yeah. We have distributed a lot, at least this one handbook at one ward it is available, and cause of death guide mobile application, it's very user friendly one, and there's a quality assessment tool in order to assess the quality, the level of quality. And we have gone, when you take preventive aspects, there are primary, secondary, tertiary. We are going even before the primordial prevention. So, we have intervened at the level of undergraduates at the medical schools. So, we initiated and we completed that, making a curriculum specially on medical certification of course of this, involving community medicine departments and forensic medicine departments, and also medical education departments. So, we have a very uniform module on this medical certification of cause of death for all the universities in the country. And we have other, for community deaths, when you take, we have SMART VA, that is verbal autopsy, and B18 amendments. Amendments you will see later. Actually, depending on the format you use, whether it is by a medical doctor in the hospitals, or whether it's by inquiry into sudden death, the formats are different, and whether you are a GP, there's another format. I am very proud to mention that with our involvement, with the participation and with goodwill by other stakeholder departments like Registrar General Department, Census and Statistics Department, we updated all these formats. Now we have completed B33, then B18, and now we go for B12, which is very important for general practitioners, right? I think within a 1 month or maximum 2, we will be able to get the new format, because all these older versions had no WHO recommended cause of death declaration. So there was a very tiny space for cause of death. Now we have updated that, and we are with the world standard as recommended by WHO. As I said, 25 hospitals above base hospital level we selected for the pilot project I mentioned earlier. 125 doctors were trained as master trainers. It was a 2-day training program conducted utilizing the premises of Directorate of Healthcare Quality and Safety. One of our resource persons we utilize is here today, Dr. Saman Gamage. So we have the uniformity in conducting our events, and the coordinators, Dr. Rangan and Dr. Maya, and they are also here, a part of this event as well. And 5 training programs from February 18 to April 18, that is the initial pilot, but later we expanded and we have trained more than that, but I am referring to the pilot. Cause of death guide mobile application introduced to participants, and training of hospital medical officers, medical officers in the hospitals by the master trainers happened then, and pre-test and post-test was conducted to assess the COD guide mobile application. And distribution of training of trainers, if you say, take here these 125 original as a pilot, the distribution is like this, the covering the whole country. And when you take the implementation at the hospital, that is was the whole purpose. They as master trainers, they go to their own premises, own institution, and conduct their training to others. Actually, before starting hospital training, they were asked to ensure that B33 form is used for cause of death writing in each hospital, and to conduct a pre-assessment for a sample of 100 death certificates in each hospital using the offline tool, which was introduced to them during the training. Coming to the evaluation and monitoring, monthly evaluation report was sent to us, Ministry of Health, by each hospital. That happened in the first week of each month. Baseline evaluation using offline tool for 100 death certificates were obtained, and 3 evaluation meetings happened. And for post-assessment, also 100 death certificates from each hospital were selected, and we analyzed that also to see the immediate output. What about the coverage? If you take the percentages, the number of intern medical officers trained was 592. That means at that particular time, 88.7% of the intern medical officers in those 25 hospitals were covered. And total medical officer cadre, when you take, it's about 3,525. That means 64.3% of the medical officers in those 25 hospitals. When you take the whole country, 31% of all the doctors were trained. So comparison with all islands statistics, 54.4% of all the intern medical officers of the country covered, and 19.7% of all the medical officers of the country covered. Right. These are the illustration of pre-test and the post-test results. You are going to be exposed to the common errors later in this third presentation. You can see the post-test results, the errors, and how was the situation of errors made by our medical doctors earlier, pre-test. The brown color, the pre-test, the errors. The blue color is the post-test. So errors were minimized. We were not happy, the missing time interval little bit, but compared to earlier, that is also much improved now. actually this is, it was the statistically significant improvement was obtained in the error count following this training. I mean, every training will lead to good behavioral change. Future plans, already all first four are achieved by us. Actually, future plans, we conducted we expanded the project to other areas as well. We want to do some more little bit in this year also, because we could not do for National Hospital of Sri Lanka and Apeksha Hospital especially. Otherwise, we have selected all other major hospitals, training, even teaching hospitals, even Kandy. So island-wide implementation of MCCOD program should happen, and this good culture should be continued, and CPD points also should be given to them. And finally, we want to activate hospital mortality review committees. Actually, we must conduct that. Nowadays it's not happening well, so we want to really start that in a good scientific way, and to make it a routine, this hospital mortality review committee. Then only really you can have a good impact on this, all these things. Now you realize that why it is so important that proper certification of cause of death. It's very then easier to identify the trends and also to identify any unusual patterns of deaths, right? And it will lead to changes and to practices, and procedures. This is how we embarked on updating the formats even. So many things, it will lead to so many things if you do this properly. And ultimately, what is our motive? To prevent all preventable deaths. Because in this setting of low resource setting, you must effectively use your resources. Then if you prevent all preventable deaths, then you have your resources effectively managed for other prioritized areas. And as all of you know, it is very rare to be born as human beings. And state-run health sector, we like to see that our people live healthy. Not just life expectancy, but healthy life expectancy. So that is what we want to do, our nation's health. So let us together save lives by quality counting of deaths. Thank you very much.
Thank you, Madam Somatunga, for your eye-opening presentation. And it's very important that you mention about B12 form. Actually, as a College of Palliative Medicine, we are more than happy to hear that next couple of months it will be upgraded and it will be available in the country. That is, I think, that is the most, I think, wanted form in palliative sector, where still our palliative providers, palliative care providers cannot contribute in full capacity without this death certification form. Our patients who needs palliative care also suffering in one hand, and the palliative care physicians also. I think, Madam, this is the greatest initiative and the milestone of providing proper palliative care in the country, to having this B12 form actually. So we congratulate and thank you for your great leadership for getting these forms updated, and it's available to Sri Lanka. So thank you so much, and let me introduce our next speaker, Dr. Saman Gamage. He's going to talk about general and specific guidelines on certification of cause of death for medical practitioners and palliative care physicians. Dr. Saman Gamage is a medical doctor who specialized in public health. He did his master's in public health in 2002. In 2014, he completed his doctoral degree in public health. His doctoral thesis was on an educational intervention to improve the quality of CRVS data in Sri Lanka. He conducted numerous research studies and published many articles on the quality of cause of death, medical certification of cause of death, and quality assessment of classification of disease. He is an international trainer in medical certification, cause of death, international classification of disease, and IRIS automated mortality coding. For the last 20 years, he has trained many coders and medical doctors in MC, COD, ICD, and IRIS in more than 20 countries. He has done several consultations for WHO and UNESCAP. Apart from the above areas, he is also a trainer in health system research. In 2015, he joined the School of Population and Global Health at the University of Melbourne as a senior research fellow. He worked at the University of Melbourne as a senior technical advisor to the Bloomberg Philanthropies Data for Health initiative until 2017. He is currently working as a consultant community physician and the head of the Department of Research and Evaluation at the National Institute of Health Sciences, Kalutara. Dr. Saman Gamage, over to you.
Good morning, everyone. Thank you very much for the very kind introduction. Dear Madam and the President of College of Palliative Medicine. So in the first presentation, you learned why cause of death certification is important. And in this presentation, I'm going to talk about general and specific guidelines for certifying cause of death. Even though this training is about death and certifying death, I would like to start with life. As doctors, we play important roles in patients' lives, no matter their ages, cultural backgrounds, or medical needs. We ask people to do what is right for their health and the health for their loved ones. We help people when they are hurt or have fallen ill. We comfort people when they are scared and not at their best. In other words, we do maximum possible justice to our patients because we have been trained to do so. With our care, most patients recover, but some may die, which is inevitable. Most of us think when our patient is dead, our duty to the patient is over, which is not correct. Our duty to the patient is still not over because we have a duty to the deceased. What is our duty to the deceased? We have to record accurate information about the causes of death or the sequence of causes leading to death and correctly complete the required documentation, specifically the death declaration form in our context. It's not only a duty to the deceased, we have a duty to the family members of the deceased because family members require a correctly filled cause of death certificate for many other purposes, including their right to know about the cause of death of their loved ones. And not only about the family, it is also a duty to the society, because society would like to know from what causes people are dying, because that is important for the planning of health policy and prevention programs. Death is inevitable. We shall all die in one day. However, it is important to know why and from what causes people die. So with that in mind, so I lined up my topics. I will first talk about cause of death and underlying cause of death, and then about the international form of the medical certificate of cause of death, Sri Lankan death declaration form, general and specific guidelines, and I will also discuss few case examples. Let me start with a small story. It starts with a dead body, as so many mysteries do. A middle-aged man is found unconscious and rushed to hospital. For 4 days he lingers in a coma. On the 5th he dies. The clues are few and dark and point in different directions. The man was a drug addict. He was diabetic. Some of his family members say that he acted strangely the last time they saw him conscious. Others disagree. The lab tests are inconclusive. Everything is inconclusive. If this were a mystery of the Conan Doyle kind, there would be a detective like Sherlock Holmes and there would be a solution. In the event, there is neither. Instead, there's a young doctor in her first year on the job, and there's a single piece of paper, a death certificate, on which she is meant to record precisely and for posterity why this person died. I copied this story from the New Yorker, and this was written by Catherine Schulz. However, this describes the sad situation of doctors who pass out from universities not having enough inputs on correctly certifying cause of death, and they face into difficult situation when they work as interns and when there is a death and having not known how to correctly certify a cause of death. Let me show you a small video clip about something that has happened immediately after death in a hospital ward.
You don't look so good. What happened?
The patient in 201 has just died. And Dr. Harkoff wants me to complete the death certificate.
So why do you look so perplexed?
Well, I only did this once in medical school. We didn't spend much time on it, so I'm not really sure what to do.
It's not that difficult. With the 3 or 4 deaths we've had recently, I've had to do a couple. So I can help you with that if you want. All right? Name?
That part I can fill out. It's the part about what he died from is what I have a problem with.
Hey, nobody killed him, so he died of natural causes.
Okay, natural causes.
Hello, hang on. He was an old man, almost 60. It was about time for him to die.
Then I'll put old age.
Well, his heart stopped beating.
So I could say cardiac arrest.
But you could say that he stopped breathing. Okay, what you put is respiratory arrest. I've been using that one quite a bit lately.
Actually, what I've been using recently is cardiorespiratory arrest. It has a nice scientific ring to it.
Hey, I think I like that one. So cardiorespiratory arrest it is.
So, as I heard from this story, cardiorespiratory arrest is a very common cause of death reported in death certificates, and many of us, including myself, have done so during my internship. So, when I consulted my senior, she advised me to write cardiorespiratory arrest. So, I didn't want to write anything else than cardiorespiratory arrest in the death declaration form. And so this signifies the importance of cause of death certification and our death declaration forms. And what you see now is the previous death declaration form known as old B33 form. You can see they are full of ill-defined conditions like septicemia, multi-organ failure, and then lots of abbreviations, and time interval is not recorded, and the causal sequence is incorrect, and all undefined underlying causes of death. So it's not only in Sri Lanka. Madam explained this graph, this map before. So this is a map indicating the quality of cause of death information across the world. The countries in dark green produce very high quality cause of death data, and light green countries produce medium high quality. And as Madam very well explained, we are producing not very low quality cause of death data. But you can see the most of the countries in Africa, they produce no reports, and many countries in the Indian subcontinent, including India, is producing cause of death data of limited use. So we are slightly better than them. Now we have done several assessments in cause of death quality. So I did an assessment of cause of death certification as a part of my doctoral thesis, and we found cause of death many quality issues, and the system is not able to identify correct cause of death in many cases. Right, what do you mean by cause of death? As defined by the 20th World Health Assembly in 1967, cause of death means all those diseases, morbid conditions or injuries which either resulted in or contributed to death, and the circumstances of the accident or violence which produced any such injuries. So in this definition, I have highlighted all those. So what does this mean? It's not a single disease, not just a single morbid condition or injury. All the causes, all morbid conditions, all injuries resulting in or contributing to death. And that's not all. If the death is due to an accident or violence, the circumstances of the accident or violence. So our doctors are very poor in reporting the circumstance. So we have some legal obligations also. Anyway, if the death is due to an injury or violence, the circumstances are important. The purpose of this definition is to ensure all relevant information are recorded, and to ensure certifier does not select some conditions for reporting and reject the others. And most importantly, the definition does not include symptoms and modes of dying, such as heart failure, respiratory failure, cardiac arrest, cardiorespiratory arrest, end-organ failure, multi-organ failure. They are not valuable as cause of death. Okay, so that is cause of death. There is another concept known as underlying cause of death. So what do we mean by underlying cause of death? When only one cause is recorded, in the death certificate, this cause will be selected for tabulation by the statistical authorities like Registrar General's Department, Vital Statistics Unit. We have trained mortality coders. They will select the single available cause in the certificate. The reported single cause then become the underlying cause of death. Single cause of death, and that is also the underlying cause of death. This is very simple. However, when more than one cause is recorded, there is need to select a single cause for reporting. This selection is done by the mortality coders using mortality coding rules. So WHO has given about 10 mortality coding rules. So we have trained the mortality coders at NIHS to use these rules, apply these rules, and to select the underlying cause of death. And the single cause selected is usually given the special name underlying cause of death. When more than one cause is recorded, coders apply mortality rules, select a single cause, and that will become the underlying cause of death. However, this selection becomes extremely difficult or sometimes can result in erroneous underlying cause of death if doctors have not properly completed a death certificate. So the application of rules are able to mitigate some of these certification errors to some extent, but the rules cannot mitigate all the errors. Therefore, correct certification is extremely important. Even though the mortality coders can apply the rules and select the underlying cause of death, that doesn't mean they can certify whatever in whatever the way they like, because the certification has to be correct. So that's why the guidelines are there. So therefore, the underlying cause of death is the condition, event, or circumstances without which the patient would not have died. Without which the patient would not have died. So WHO has given a definition for this: the disease or injury which initiated the train of morbid events leading directly to death, or the circumstances of the accident or violence which produced the fatal injury. So this definition was given, my citation is 1994 WHO ICD volumes, but even before this definition was there. So there are two components in the definition. If the death is due to a disease, so we have to find out the initial event in the chain. If the death was due to an accident or violence, the circumstances of the accident will become the underlying cause of death. Right, let's go through an example. A cancer patient dies. The immediate cause of death was congestive cardiac failure resulting from carcinomatosis, which is widespread dissemination of carcinoma in the body. The original neoplasm site was colon. The patient had a neoplasm in the colon and it disseminated throughout the body, and finally the patient died of congestive cardiac failure. If you arrange the events in a sequence, we have malignant neoplasm of the colon leading to carcinomatosis. Carcinomatosis led to congestive cardiac failure, and finally death. The direct cause of death or the immediate cause of death is congestive cardiac failure, while the underlying cause of death was malignant neoplasm of the colon. However, if this patient was admitted to the hospital without any previous history of neoplasm, or if the doctor did not consider about the past history, the patient will be treated as a case of cardiac failure. And if the patient dies, the cause of death will be recorded as congestive cardiac failure, and finally it will be categorized as a cardiovascular death, whereas the actual cause of death was malignant neoplasm of the colon. So no matter the duration between the onset of neoplasm and the death, if the congestive cardiac failure was caused by carcinomatosis and by no other cause, the underlying cause of death is malignant neoplasm of the colon. From the current terminology, malignant neoplasm of the colon is the starting point, and congestive cardiac failure is the terminal event. International standard death certificate was introduced by World Health Organization, and this certificate is designed to facilitate reporting the chain of events leading to death in a sequence. So this is recommended by World Health Organization for certification of death in all countries. Now what we are seeing now is the 2016 version of medical certificate of cause of death, which has 3 main sections. It has part 1, medical data part 1, then part 2, and then there is a time interval column. In part 1, there are 4 lines, 1A, 1B, 1C, and 1D. The form itself is self-explanatory. You can see the arrows directing upwards. That indicates the sequence. And you can also see in between lines, due to is printed. So in line 1A, doctor should record the immediate cause of death or the direct cause of death. And then in the subsequent lines, they can record the other causes in a sequence, and the underlying cause of death will be reported in the lowest used line. And part 2 is to record other significant conditions that may have contributed to death. And then there is a column to the right to enter the time interval. This is to enter the approximate time interval between onset of each of these conditions and death. Therefore, there are 3 main sections. Part 1 for the reporting of diseases or conditions directly leading to death. Part 2 for the reporting of other significant conditions. And then a column to record approximate interval between onset and death. That's the time interval column. Part 1, sequence of events leading to death. Part 2, other significant conditions contributing to death. Please note the terminology that we have used, contributory causes. Part 2, contributing to death, and then time interval column to report the time interval. So let's see how this form will be completed. In line 1A, we report the direct or immediate cause of death. In the previous example, it is the congestive cardiac failure. If the condition reported in line 1A is due to another cause, this will be reported in line 1B. So what you report on line 1B is the cause of the condition in line 1A. If the condition reported in line 1A was due to another condition, so this will be reported in line 1C. In other words, so this is the cause of the condition in line 1B. And if the condition on line 1C was due to another condition, so this will be reported on line 1D. So this will be the first event in the sequence and the cause of the condition in line 1C. So if you have done this, when you reach line 1D or the lowest used line, you have identified the originating cause of the sequence. So this is where the sequence started. And when you reach there, you are closer to the time when the patient was healthy. Before this illness, most probably, patient was living healthy, and the whole agony started with the onset of this disease. So, underlying cause of death is reported in the lowest used line. In the train of morbid events, it is the last wagon which is important. In a train, the main compartment is the engine, which is most important, but in the train of morbid events, the last wagon is more important. The Last Wagon is a famous movie, very old movie. Now, in 2015, after a research study and following some recommendations, Registrar General's Department decided to implement a revised death declaration form, which is known as a Registration B33 form. So this was officially launched from 1st of January 2015 to certify causes of death in hospitals. So this form is available in triplicate. It's a carbonized form. Unlike the previous death declaration form, which is very ambiguous, so this is very clear, and it is in accordance with the WHO standard guidelines, part 1, part 2, time interval column, and everything is there. And less documentation work for the doctors, because in the previous form we had to complete the counterfoil as well. Now with a single completion, so they are completing 3 copies. So this form is available and some administrative information is available in the first section, and this is the identification data section. The completion of these parts are also important, and then this is the medical data section, and all hospitals should make sure this form is used in the hospital, because when the new form was introduced, some hospitals were still using the old format because they was thinking that they have to finish the old forms to start with the new form. But as I can remember, Director General of Health Services issued another circular asking the hospitals to use this form mandatorily. Right. So death certificate is, when it is completed, it goes to the mortality coders for ICD mortality coding. And what you are seeing here is the ICD volumes, the 10th revision of International Classification of Diseases, which is managed by World Health Organization. And as a result of ICD mortality coding, we can tabulate coded data, and these tabulated coded data forms the national mortality statistics. And they are used for planning and policy and fundamental for prevention of premature deaths. Right. Let's discuss a few case examples. A 50-year-old woman was admitted to the hospital vomiting blood and was diagnosed as having bleeding esophageal varices. Investigation revealed cirrhosis and portal hypertension. The woman had a history of hepatitis B infection. 3 days later, she died in the hospital. So if we organize the causes in a sequence, she had hepatitis B, and hepatitis B may have caused liver cirrhosis, and due to liver cirrhosis she developed portal hypertension, and due to portal hypertension she developed bleeding esophageal varices. So this is the immediate or the direct cause of death that should be reported on line 1A, and then there are antecedent causes, line 1B portal hypertension, and line 1C liver cirrhosis, and then the underlying cause of death, the originating cause of the sequence, should be reported on line 1D. So this is the starting point, and this is the terminal event. So it's very important that doctors construct this sequence and complete the death declaration form accurately. So our advice to doctors is not just don't write straight away in the proper death declaration form, because you cannot erase or alter. It's a carbonized form. Better to construct the sequence in the bedhead ticket or in another piece of paper, and when you are satisfied that the causal sequence is correct, then you can copy it down to the proper death declaration form. So it's the best way to complete the form. Why is it important to report the sequence? It gives us an overview of the total process leading to death. We are able to receive much richer information about common causes of death. It's true that underlying cause of death is the most important, but other causes are also important, because they are that indicates the disease pattern, the common causes and common conditions treated in the hospital. All these information are useful. So it shows us, most importantly, the possible points for intervention to break the chain and to prevent the death, because we have the causal sequence, the chain of events, so we have to break this chain to prevent the death. Now in this chain, so what are the points for intervention? Prevention of hepatitis B. So preventing hepatitis B progressing into cirrhosis, if there are any medical measures. Management of liver cirrhosis, the facilities, physicians, drugs, equipment, and treatment of bleeding esophageal varices, blood transfusions, sclerotherapy, endoscopy, all the facilities. So that indicates all the points for intervention and also the causal sequence. So all these information are important. It's not just hepatitis B, other conditions are also important, and they are recorded, they are coded and recorded. So these information are available. Let's discuss another case study. A man dies of cerebral hemorrhage due to secondary hypertension due to chronic pyelonephritis. Patient had benign hypertrophy of prostate gland. He has been a known diabetic too. So it's a known diabetic having benign hypertrophy of prostate, and then developed chronic pyelonephritis and secondary hypertension and died of cerebral hemorrhage. So benign hypertrophy of prostate can cause chronic pyelonephritis due to outflow obstruction, and chronic pyelonephritis can lead to secondary hypertension and finally cerebral hemorrhage. So immediate cause of death is cerebral hemorrhage, reported on line 1A. Antecedent causes are secondary hypertension and chronic pyelonephritis, reported in line 1B and C. And underlying cause of death is benign hypertrophy of prostate, and this should be reported in line 1D. Diabetes mellitus, which is not within the sequence, type 2 diabetes mellitus, can be reported on part 2, as a contributory cause. So this is the starting point and this is the terminal event. However, this completion is based on the best medical opinion of the clinician. So clinician makes this decision depending on the information available to him or her at the time of certification. So he decided chronic pyelonephritis was caused by benign hypertrophy of prostate. However, there can be another sequence, alternative sequence, because in this case history we did not know about the patient's diabetes status. We didn't know how well the diabetes was controlled, and we don't know any information about severity of outflow obstruction caused by prostatic hypertrophy. Another clinical opinion is diabetes mellitus could have been the reason for chronic pyelonephritis. So it's up to the clinician to decide this. So if clinician decides diabetes was caused in chronic pyelonephritis, the sequence will be like this. Diabetes mellitus caused in chronic pyelonephritis leading to secondary hypertension leading to cerebral hemorrhage. Then the underlying cause will be diabetes mellitus, and benign hypertrophy of prostate will be a contributory cause. So this can be decided by the physician using the available information. Therefore, for correct medical documentation, death certificate completion, a proper medical record documentation is also important, because everything should be correctly documented in medical records. There is another explanation to this. We assume chronic pyelonephritis was due to prostatic hypertrophy. And if we assume the prostatic hypertrophy started 15 years ago, and there is a long duration for the causation of cerebral hemorrhage, and we do not know whether the secondary hypertension actually led to cerebral hemorrhage, because the causation of cerebral hemorrhage is multifactorial. It's not only hypertension. So someone would like to report cerebral hemorrhage as the underlying cause of death, and secondary hypertension, chronic pyelonephritis, diabetes mellitus type 2, and benign hypertrophy of prostate as contributory causes. So this is another school of thought and another explanation. So that depends on the decision of the clinician. We know many doctors report cerebral hemorrhage is caused by hypertension. However, during the mortality coding process, we don't consider cerebral hemorrhage is caused by hypertension, because there are many hypertensives in the society. Not all of them develop cerebral hemorrhage, because it's not only hypertension that contributes to cerebral hemorrhage, the causation is multifactorial. So cerebral hemorrhage can be a separate entity, and it will be selected as an underlying cause of death. So important points are: always use consecutive lines starting at 1A. Never leave blank lines within the sequence of events. If there is only one cause of death, it is entered at line 1A. Each condition below 1A is a cause of the condition above it. That is, it is an antecedent cause. The initiating cause is the sequence, in the sequence is the underlying cause of death. Okay, let's discuss another example. A 56-year-old man dies from acute myocardial infarction within 3 hours of its onset. his ECG and enzyme levels confirmed the diagnosis, and he did not have any other illness. So in such situations, the cause of death certificate will have only one cause of death: acute myocardial infarction, 3 hours. And this is correct. And then the next question is, so you may complete a death certificate with 2 courses or 3 courses or maybe 4 courses, and sometimes you may find more than 4 courses in a sequence. So what if there are more than 4 courses to report in the death certificate or in the sequence? Because part 1 has only 4 lines. In some countries, I know in US they have 5 lines, 1A, 1B, 1C, 1D and 1E. And in some countries they only have 3 lines, 1A, B and C. So number of lines is not that important if you can report the causal sequence correctly. Now what is the solution? If you have more than 4 courses in the sequence, you have 2 options. You can add another line 1E and record the underlying cause of death in that line. So this is one possible option. However, in our carbonized form, it is not that easy. So due to some other problems, may not be copied accurately. Alternatively, you can report 2 conditions in line 1D using due to in between. Anyway, for the reason that you do not have enough lines in part 1, you should not record the underlying cause of death in part 2, because we have space in part 2, but part 2 is meant to report contributory causes, not for the causes in the sequence. So this is an example how you would complete the cause of death certificate when there are more than 4 conditions to report in part 1. So 1A, cerebral edema, 1B due to cerebral hemorrhage, and cerebral hemorrhage was due to secondary hypertension. And in line 1D, you can write chronic pyelonephritis due to benign hypertrophy of prostate, clearly indicating the timelines, time intervals. So when you write like this, the coders will assume these 2 conditions were meant to be in 2 succeeding lines, 2 different lines. However, if you report chronic pyelonephritis, benign hypertrophy of prostate, coding rules will be applied differently. Then we have multiple causes on a single line, and we have separate rules to manage that. So always we have to use some sort of terminology: chronic pyelonephritis secondary to benign hypertrophy of prostate, or benign hypertrophy of chronic pyelonephritis caused by benign hypertrophy of prostate. So you have to indicate a causal sequence. Let's move on to part 2. How to complete the part 2 of the certificate. Part 2 of the death certificate records all other significant or contributory diseases or conditions that were present at the time of death but did not directly lead to the underlying cause of death listed in part 1. So if you report any condition in part 2, the condition should be present at the time of death. So you cannot report past medical conditions. For example, patient had cholecystitis and cholecystectomy done 10 years ago, so you cannot write cholecystitis. The condition should be present at the time of death, and this condition should not directly lead to the underlying cause of death in part 1. Another example, a 60-year-old hypertensive patient was admitted to the surgical casualty ward with severe abdominal pain and vomiting. She was diagnosed as having a strangulated femoral hernia with a bowel perforation, She underwent surgery to release the hernia and resect the intestine with an end-to-end anastomosis. And 2 days after the surgery, she developed signs of peritonitis and died 2 days after. Now, before I give you the solution, I must tell you, according to the Ministry of Health guidelines, if a death happens following surgery, the medical ward or surgical ward medical officer should not complete the death certificate. So this goes to the judicial medical officer. Anyway, the correct way to complete this is peritonitis caused by bowel perforation due to strangulated femoral hernia. You may or may not report the name of the surgical procedure on the death certificate. Even though you report the name of the procedure, it will not be coded by ICD-10, and hypertension is reported as a contributory cause in part 2. Then I will also describe how to report the time intervals, approximate interval between onset and death. So there is a column on the right hand side of both part 1 and part 2 of the death certificate for recording the approximate time interval between the onset of the condition and the date of death. So when you report time intervals, if the time of onset is unknown or cannot be determined, you can write unknown. However, it's very important not to leave this column blank. So if you leave it blank, what will happen is sometimes we conduct assessments of medical certification of cause of death. If the column is blank, we assume that time interval is not reported. If the time interval is not known, you can write unknown. And you can also use general terminology such as weeks, months, days, because patients will say, I had diabetes for several years. So he doesn't know the number of years, so you can write several years. Or if you know the exact duration, you can write 5 years, 10 years, 15 years. This information is useful for coding certain diseases and provides a check on the accuracy of the reported sequence of conditions. For example, if you have completed the certificate accurately, the time interval should be in the descending order from bottom upwards, because the most recent event is in line 1A and the most remote event is in line 1D. So that indicates the accuracy of your sequence. And also, time duration is important in coding. One example is a stroke 2 years ago will be coded as a sequelae of stroke, and it has a different ICD-10 code. Stroke 1 month ago will be coded as an acute episode of stroke. So it's a different code, different ICD code. So underlying cause of death selection will be different. So therefore time intervals are important, even though doctors are very reluctant to report time intervals. Then talking about specific conditions, for example, certifying deaths due to neoplasms. There are 3 specific aspects of neoplasms that we have to consider when we report neoplasms: the behavior, morphology, and the site. Behavior, whether it is a benign neoplasm or a malignant or uncertain or carcinoma in situ, so whatever the behavioral type should be reported. Morphology, if morphology information is available, whether it's a lobular carcinoma or squamous cell carcinoma or clear cell carcinoma, if histopathology reports are available, should be reported, because we can assign ICD codes for the morphology. And anatomical site is extremely important, because cancer prevention programs are conducted. These programs are organized based on the site of origin of the neoplasm, because we have breast cancer prevention programs and oral cancer, different types of cancers. So sight is extremely important. So these three aspects should be considered as important. Then for secondary neoplasms, if the primary site is known, it must be stated. For example, primary carcinoma of the lung. Maybe the patient died of the secondary neoplasm, but if the primary is known, even the primary cancer has been previously operated, and if it is no longer there, still we have to report the site of the primary cancer. Sometimes primary cancer was operated, mastectomy was done, and now the patient has secondaries in the lung. If the primary site of the secondary neoplasm is unknown, primary unknown must be stated on the death certificate, because we have ICD codes for primary unknown cancers. We have different ICD codes. Let's discuss another case scenario. A 78-year-old female with a temperature of 102.6 degrees of Fahrenheit was admitted to the hospital from a nursing home. She first became a resident of the nursing home 2 years earlier following a cerebrovascular accident, which left her with a residual left hemiparesis. Over the next year, she became increasingly dependent on others to help with her activities of daily living, eventually requiring indwelling catheter 6 months before the current admission. For the 3 days prior to admission, she was noted to have lost her appetite and to have become increasingly withdrawn. On admission to the hospital, her leukocyte count was 19,700 and she had pyuria, and gram-negative rods were seen on a gram stain of urine. Ampicillin and gentamicin were administered intravenously. On the third hospital day, admission blood culture turned positive for Pseudomonas aeruginosa, which was resistant to ampicillin and gentamicin. Antibiotic therapy was changed to ticagrelin clavulinate, to which the organism was sensitive. Despite the antibiotic and intravenous fluid support, the patient's fever persisted. On the fourth hospital day, she became hypotensive and died. So this patient has been in an aged care, maybe in a palliative care setup, and died of following a catheter and then septicemia most probably caused by a urinary tract infection. So patient had left hemiparesis due to old cerebrovascular accident, and because of that she was on catheter, and she developed Pseudomonas aeruginosa urinary tract infection and died of Pseudomonas aeruginosa sepsis. So if we know the organism causing septicemia, it's better to report the organism, because ICD codes can be assigned. Then another important aspect is reporting deaths due to diabetes mellitus. As we know, diabetes can be a risk factor as well as an underlying cause of death. As a general rule, if the patient dies from a complication of diabetes, for example diabetic nephropathy, document diabetes mellitus type 1 or 2 as the underlying cause of death. However, if the patient dies from stroke or acute myocardial infarction, document diabetes in the part 2 as a risk factor to the underlying cause of death. Now this chart was prepared by someone else, and this explains the causes of diabetic deaths, because diabetes has metabolic complications, direct microvascular changes, associated microvascular changes, and it will also act as a contributory cause. So metabolic complications like ketoacidosis or hyperosmolar coma, hypoglycemia, and then it can cause peripheral vascular and neural gangrene and sepsis and diabetic renal disease. So where the diabetes will become an underlying cause of death. However, in the cases of myocardial infarction, stroke, or other causes, it will become a contributory cause. In the recent past, we had deaths due to COVID-19, and they are not very much reported right now, but at the beginning of the pandemic, WHO assigned 2 ICD codes to code COVID-19. For virus identified COVID-19, U07.1, and for the epidemiological diagnosis of COVID-19, U07.2, when there is a contact history and the report is not available, or for some reason a test was not done, then we code it to U07.2. And later on they introduced some other additional ICD codes for U08, personal history of COVID-19, U09 for past COVID-19 condition, and another important code is U10 for multisystem inflammatory syndrome associated with COVID-19, and then for adverse effects of COVID-19, U12. Therefore, completion of death certificates due to COVID-19, for deaths due to COVID-19 is also important, and I have a couple of examples to guide clinicians on reporting COVID deaths. A 45-year-old person who had recently traveled overseas was admitted to the hospital with a 3-day history of fever and sore throat. The nasopharyngeal swab was positive for COVID-19. On the day of admission, the patient developed breathing difficulties and was diagnosed with pneumonia. On the 5th day of hospitalization, the patient developed severe respiratory distress and died soon thereafter. Patient had a 15-year history of type 2 diabetes and a 10-year history of hypertension. So if you report this, in 1A, you can report severe acute respiratory distress syndrome, 1 day, pneumonia, 5 days, and coronavirus disease, COVID-19 laboratory confirmed, 8 days. And in part 2, other contributory causes can be reported, hypertension for 10 years and diabetes mellitus type 2 for 15 years. So this is a death due to COVID-19, confirmed COVID-19 death. Another example, a person was diagnosed clinically as having COVID-19 because the laboratory testing facilities were not available at that time. The patient was a known asthmatic for 10 years and finally died of respiratory distress. So we can write acute respiratory distress syndrome, pneumonia, and probable COVID-19 because virus is not identified. Upon clinical suspicion, we can report it, and bronchial asthma will be reported in part 2, and this is considered a probable COVID-19 death. However, some countries have different policies. Some countries, even though the test is positive or negative, they considered all these deaths as confirmed COVID-19 deaths. Another example is the patient had COVID-19 and then while receiving treatment, and then the patient became tested negative and finally developed a chest pain, and ECG showed evidence of myocardial infarction, and coronary angiography was done and demonstrated severe multivessel coronary artery stenosis, and 2 hours after angiography the patient died, went into cardiac arrest and died. So this is a myocardial infarction caused by coronary arteriosclerosis, and COVID-19, hypertension and diabetes mellitus and smoking history can be reported in part 2 as contributory causes, and this is not a death due to COVID-19. And some general instructions for certifying cause of death for doctors to be mindful of. In most countries, coders are not medically trained. Our coders are not medically trained. They're not even working in the hospital. They're in the Registrar General's department. When we trained them at NIHS for the first time, they were just data entry operators. And even a small misinterpretation may result in confusion and incorrect underlying cause of death selection. Therefore, clear, legible documentation is very important. And you have to correctly complete the identification data, including correct spelling of the names. So this can result in so many problems to the family members when the name is wrongly written on the death certificate. So misspelled or wrong names can result in confusion, especially for insurance and inheritance purposes. Then document only one condition per line as guided. Use consecutive lines. Record time interval. Avoid using abbreviations unless it is a very common abbreviation like HIV or COVID-19. And then check the document on clear sequence of events leading to death. Do not enter ill-defined conditions as underlying cause of death. And all entries must be legible. Use black or blue ink. Better not to use other colors, because other colors will not do very well with photocopying and scanning. Sometimes these documents may be photocopied or scanned for legal purposes. And do not make alterations or erasures. So it's not possible to alter or erase in a carbonized form. Therefore, if you want to delete something or erase something, don't try to erase or delete. Just delete, draw a single line across and rewrite the correct version, and do not use correction fluid because it's a legal document. If you alter, this can be argued in a court of law as possible tampering. So that's not good. Okay, that's all content-wise. That's all I have to discuss. If I have time, I can discuss few case scenarios with you all. Do I have some more time? Okay, I will display the scenario and then we can discuss the causal sequence. I have, I think, 3. A 42-year-old woman complained about a chronic ulcer in her right foot, which she had for the last 3 months. She also complained of fever and serosanguinous discharge from the ulcer during the last week. Her past medical history also showed diabetes mellitus type 2 for 8 years. Necrotizing fasciitis was the diagnosis for this admission. High doses of antibiotics were given to her after wound cleaning. 3 days later, she still had high fever. Plain film of right foot showed osteomyelitis, fragments of metatarsal bones with air shadow in foot tissues. 1 day after, she had septic shock and sudden cardiac arrest with unsuccessful resuscitation. So what could be the possible sequence leading to death? So from the history, it is clear that she had diabetes mellitus and had an ulcer and developed necrotizing fasciitis, and the history says she went into septicemic shock and finally to cardiac arrest. So the immediate cause of death is septic shock, and she had acute osteomyelitis, right metatarsal bones, and necrotizing fasciitis in the right foot, diabetes mellitus type 2 with a ulcer in right foot. So this is a diabetic ulcer. So she had this for diabetes mellitus she had for 8 years and the ulcer for 3 months. Necrotising in fasciitis for 12 days. Osteomyelitis was detected 4 days ago. And septic shock lasted only 1 day and she died. Another example, a 34-year-old male was admitted to the hospital with severe shortness of breath. He had a 9-month history of unintentional weight loss, night sweats and diarrhea. The patient had no history of any medical condition that would cause immunodeficiency. An ELISA test confirmed Western blot test for human immunodeficiency virus were positive. T lymphocyte test indicated low T helper suppressor ratio. A lung biopsy was positive for pneumocystis carinii pneumonia, indicating a diagnosis of acquired immunodeficiency syndrome. The patient's pneumonia responded to antibiotic therapy and the patient was discharged. Patient had 2 additional admissions for pneumocystis carinii pneumonia. 17 months after the patient was first discovered to be HIV positive, he again developed pneumocystis carinii pneumonia but did not respond to therapy and he died 2 weeks later. So it's a clear case of pneumocystis carinii pneumonia caused by acquired immunodeficiency syndrome due to HIV infection. In some places, there is a social stigma about reporting HIV in death certificates, and this question is asked by many physicians. However, if the patient is HIV positive and if the patient died of AIDS, we have to report it in the death certificate. I have seen in some countries they write immunodeficiency or retroviral infection. Common diagnosis is retroviral infection, just to undermine, not to directly write HIV infection. All right. Okay, thank you very much. If you have any questions, I am happy to answer.
Thank you very much for very informative lecture. Now I think we know what is the starting point and what is the terminal event and where to put contributory conditions, and I think this is very important to know. Each and every one of us has to do day-to-day practice. So thank you so much once again. Then the last topic is gaps in certifying of causes of deaths by medical practitioners by Dr. Rangana Vadugedara. So let me introduce Dr. Rangana Vadugedara. He is a health informatics professional attached to the Office of the Additional Secretary Public Health Services at the Ministry of Health. He obtained his MBBS degree from the University of Colombo in 2011 and master's degree in biomedical informatics from the University of Colombo in 2019. He completed action research for his MSc on a mobile application for doctors to improve recording of causes of death. And this mobile application was used during the implementation of medical certification of cause of death program in Sri Lanka, which led to quality improvement in medical certification. He contributed as a health informatics expert and as a trainer during the pilot project on smart verbal autopsy conducted in 2018 to evaluate the community deaths in Sri Lanka. He had completed a fellowship program at University of Melbourne on development of an e-learning course in medical certification in cause of death in 2019. Currently, he works as a coordinator to the CRVS improvement activities led by the Ministry of Health. And he also a council member of College of Palliative Medicine of Sri Lanka. So, Dr. Angana Vadugedara, it's over to you to talk about gaps in certifying of causes of death by medical practitioners.
Thank you very much for the kind introduction. Good afternoon to everyone. Today I want to draw your attention to the topic, the gaps in certifying cause of death by medical practitioners. While we may have well-established system of medical certification of cause of death and mortality statistic generation, the quality of cause of death information is still suboptimal. It was explained during the first session. And it is crucial that we recognize the importance of improving quality of cause of death and acknowledge the central role that medical practitioners and palliative care physicians have in achieving this goal. During the next 10 to 15 minutes, I will explore the gaps in certifying cause of death by medical practitioners and the reason behind them, and some potential strategies to enhance the accuracy of quality of cause of death information given by the medical practitioners. Thank you for joining us today, virtually as well as physically. We all know a well-functioning civil registration and vital statistics system is critical for effective governance and protection of individual rights. It allows the government to accurately track the vital events such as births, deaths, and marriages, and provide legal documentation to access the service benefits and entitlements. Moreover, a functional CRVS system generates reliable and timely data that can inform evidence-based policy making and resource allocation. However, the quality of mortality data produced by the Sri Lankan CRVS system is matter of concern. Despite the high level of registration completeness, the accuracy and timeliness of mortality information generated through this system is not up to the standards. According to the leading cause of death report published in 2015, the disease of the circulatory system were responsible for the highest proportion of deaths in Sri Lanka, accounting 25% of the deaths. Unfortunately, a significant proportion of mortality data produced in Sri Lanka is unusable for public health policy making and disease and prevention strategies. The second leading cause of death is categorized as symptoms and sign and abnormal clinical laboratory findings, not elsewhere classified. This category of data provide little value in developing health policies and prevention strategies. The problem of unusable mortality data is due to incomplete death registration practices done by doctors as well as other categories who do certification such as coroners and Gramaniladaris. The study done by Rasika Rampatige, Saman Gamage and Alan Lopez on the topic assessing the reliability of cause of death report by the vital registration system in Sri Lanka found that the majority of medical records were average quality, indicating that certificate of cause of death in Sri Lanka are frequently incorrect and limiting their usefulness for health policy and monitoring development goals. And also, after discovering the inadequate mortality statistics in Sri Lanka, the Sri Lankan Medical Association (SLMA) published a action plan in 2017 in their newsletter to improve the quality of mortality statistics. The plan addresses the overall poor quality of mortality statistic, which the SLMA considered totally useless for the public health planning. And majority of factors given in cause of death certificates should be improved. That is 30 to 40% unusable data. The SLMA publish in their newsletter. So how we can assess the quality of mortality data? The easiest way to evaluate the quality of cause of death certification is by looking at the commonly done errors. So we inspect the certificates and look for common errors. These are the few common errors done by certifiers during medical certification. Let's look at these errors so that we understand these errors and prevent these errors when we are certifying. Multiple causes of deaths per line. The second error, the missing time interval from the onset. Use of abbreviations in certifying cause of death. Illegible handwriting. Incorrect or clinically improbable sequence of deaths. The first condition entered in the lowest use line of part 1 cannot be the underlying cause, such as impossible underlying causes, intermediate causes, mode of dying such as cardiac arrest, and unspecified causes within the larger sequence of death category. And also some other common errors such as for deaths due to external causes, accidents, the circumstance related information are missing. And also, as mentioned in the previous lecture, deaths due to neoplasm, the additional details such as site, morphology and behavior is missing. Errors related to completeness of the certificate such as full name should be mentioned. So those are the other type of errors. So we as medical practitioners and palliative care service providers, we should always aware about these common errors that we are doing in certifying cause of death, and we should try to prevent these common errors. So let's look at some of the errors and examples. First error, the multiple causes of deaths per line. So as WHO guideline says, we cannot enter two conditions in a single line of cause of death certificate. So if we enter two conditions, it can be considered as an error. But if we use the term due to, or if we write in a separate column, so it will considered as a correct certification practice. So if you look at this is one of the B33 form filled by a hospital medical doctor. So I think we can find few errors. So in line 1A, two conditions have been entered, and also there are abbreviations used by the doctor, and also the time interval is also not written correctly. So in this certificate, in line D, 1D, two conditions written, but they have used the term due to and specified that it is two condition, and so this will be not considered as an error. The missing time interval from the onset to death. Actually, this is the most common error the doctors are doing. So when we are doing the quality assessment, we found this is the most common error we are doing. The time interval, as mentioned in the previous lecture, is one of the very important thing we should consider, because it will help the ICD coders to identify the sequence of death correctly, and it will facilitate the process of ICD coding. We should keep in mind that always the ICD coding is not done by medical professionals. It is done by trained ICD coders. So we should always give our maximum contribution to get the best ICD code out of the certificate we are writing. In these certificates, it is nicely written, all the conditions, but time interval is not given. Use of abbreviations. So, as I said earlier, the coders are not medical person, so they cannot understand our abbreviations. And sometimes the abbreviation can mean two conditions. If we write CVD, it can be cardiovascular disease or cerebrovascular disease. So it is always advisable not to write any abbreviations, but standard abbreviations like COVID-19 are acceptable to write in the death certificate. Here also a real death certificate written, B33 certificate written in hospital, all are in abbreviations. So doctors are known to have illegible handwriting, but this is a legal document and we should always write the certificate very clearly, including the name and other demographic details, because sometimes this will affect the persons and relatives after the certification, especially when it comes to their inheritance and everything and insurance claims. So this will affect. So it is very important we write the certificates very clearly. Incorrect or clinically improbable chain of events leading to death. So as mentioned in the previous lecture, we should always try to write the sequence first in a piece of paper and then write the sequence in the cause of death certificate. Sometimes we advise all the interns always write the sequence in the BHT and get the consensus from their consultant first before writing in the death certificate to avoid any sequence errors. So in this certificate, the hepatic encephalopathy caused by chronic liver cell disease and diabetes mellitus. We all know there is no direct causal relationship between diabetes mellitus and chronic liver cell disease. So most probably diabetes mellitus should come to the part 2 of the certificate. A similar error, diabetes caused by gangrenous foot and chronic bronchitis. So sequence is totally incorrect. The first condition entered in the lowest use line, part 1, cannot be an underlying cause. This means the underlying cause is not written properly. So we can't write symptom and signs such as abdominal pain, chest pain, cough, fever in these death certificates as a cause of death. And intermediate causes such as septicemia, secondary hypertension, pathological fractures. And also mode of dying such as cardiac failure, ventricular failure, cardiac arrest, respiratory arrest, cardiorespiratory arrest or cardiorespiratory failure. Those are mode of dying but not standard cause of deaths. And also unspecified causes within a larger death category, such as if we write congenital heart disease, it's a large category, so we can't identify what is the exact congenital heart disease the patient was having. So in this certificate, intermediate cause has been written as septicemia without any specifications. Other errors, it is very important for palliative physicians to describe the deaths due to neoplasm in a correct way by mentioning site, behavior, whether it's benign or malignant, and whether it's primary or secondary, and also the histological type. And also, if the site of any primary neoplasm is known, it should also be mentioned in the certificate. When certifying death from injuries and other external causes, road traffic accidents and other injuries, site of the injury, type of the injury, whether it's a laceration, abbreviation, fracture, should be specified. Mostly these injuries go through the medical legal system and certified by judicial medical officers or the coroners. So, but it is important as doctors, we know that death following injury, all this information related to death, site of the injury and type of injury are very important when producing ICD codes and mortality statistics. So we know the squamous cell carcinoma is the most common malignancy in the tongue, but here the histological type is not mentioned and also the time interval not mentioned. So these are the errors we found when we inspect the real death certificates. So in Sri Lanka, to improve these gaps in the system, timeliness and quality of the mortality information, we have taken steps to address the system through implementing a digitalized information system called Monitoring and Evaluation of Mortality Statistics in Sri Lanka. This collaborative project involved the Ministry of Health, Registrar General's Department and the Department of Census and Statistics. Monitoring and Evaluation of Mortality Information System, or the MNEMS, capture the cause of death data written by doctors, Ramaniladaris, ISDs and all the relevant people at the divisional secretariat level now. So all the death certificates will be entered to a digitalized system, and this system is embedded with the quality assurance system. So all the death certificate will undergo a quality assurance, quality check at different levels. So it is very important as medical practitioners, we try our best to prevent any errors, because this system is going to capture all the errors we are doing. And this MNEMS system is expected to produce timely mortality data and improve the quality of data through its inbuilt monitoring and evaluation system. The MNEMS system was launched in March, and with the input from medical practitioners, the system can be enhanced to generate timely and precise mortality data, ultimately leading to improved outcome. So we would like to give the message to all the medical practitioners, medical doctors, that with this system we can improve the mortality data system in the country, but we should always do our certification very correctly. Thank you very much.
Thank you very much, Dr. Rangana, for finding the gaps and mistakes of medical certification, and it's very important, and I'm sure hereafter we will not forget to put time interval, no? Yeah, so thank you so much. And the eligibility of writing, handwriting, and it's very important to have a correct and good death certificate, I realize that. So for so many things, as palliative physicians who are providing palliative care, so this is very important, mainly the hospice setup and the home setup. We are facing a lot of problems as GPs and as palliative care providers. So this webinar, I think we got a lot of very valuable informations, and now I will open the floor for 5 minutes to ask any questions or clarifications or any comments from the expert panel. Yes, please.
Thank you. And I'm very much convinced now how important this is, like fill in the medical certificate, the certificate for cause of death. But today I check in a Registrar General's website, right? I'm a general practitioner working in the community. So as you said, madam, like 50% of death are reported from the hospitals. So others are from the community, it has to be community. So, but in that, for the deaths occurred in home, there's no role for medical practitioners. They say Gamaniradari can report, like family member has to report to the Gamaniradari and he can write the cause of death. So how do you, Gamaniradari, a layman, can decide about the cause of death? That is one question. So.
Thank you for the question. First thing is Birth and Death Registration Act, or the BDRA, is the main piece of legislation governs the death registration process in Sri Lanka. So it has given clear provision to certify cause of death for community deaths or the deaths occurring at home by the general practitioner or registered medical practitioners. So there is a clear legal provision for that. And also there is a form called B12 that can be used by general practitioners to certify cause of death. For that, the general practitioner should have seen this patient before and treated and knows about the condition. Unfortunately, this B12 is outdated form and not having the WHO standard of cause of death certification. So we are in the process of updating that, and we are at the last edge of that process, as madam mentioned. So under the leadership of our madam, so we have drafted the new form and submitted for final approval, and hope it will come within next month or next 2 months. So it will come with a circular as well from the Registrar General, so that general practitioners can always certify deaths if they are competent about this death. If it is a natural death and there is no suspicious, they can certify. And also the other thing is, if the Gramanilidar is certifying, doctors can always give the cause of death in their letterhead with their seal and signature. So the Gramanilidari will use that cause of death to fill the certificate. Oh, I think madam will also add something to that.
It's a chain of events and the happenings coming from the colonial era. Considering the convenience, Grama-Diladari is playing a role in this chain of events. But that is not the best scenario, the country, but at this particular moment we are not going to go for a system change, but improve at that level. But we'll see the next step of development should be actually even a death happens in the community to be certified by not the confirmation is always by a medical professional, but also the certification also should be by a medical professional one day.
Thank you, madam. And one more question. About this, I realized when I was practicing in the hospital, we give this B33 form in English, right? We fill it in English and they take it to the registrar and he fills it in Sinhala language. So which one you consider for the mortality data? Like, is it the Sinhala one, or is it the, like, I think that this original B33 is not attached to, right? It's only the communication between the registrar and the hospital.
No, actually this digitalized system use B33. They look at the B33 and enter. And previously also the coding was done by looking at the B33, not at the death certificate.
Yeah, okay. So that's good, because most of the time we get calls from the death registrar telling that I don't know what this is, like, you know, I don't understand what is it, like that. And madam, like when we evolve in with this death certificate, like if we are going to give the power to, or the responsibility to community physicians, doctors working in the community, who will, like, you know, compensate for that. So because it will be important for to maintain the quality, because it takes time, right? You know, so many steps. So you might have to go through all the medical records for that. And then we cannot charge from the patient, because now like there are so many like people in different economical backgrounds. So far I realized that this is a requirement of the family, because they want to get the death certificate. But not only that, the government also, now I know very well that there's a it's a requirement, right, for the Ministry of Health also. So when you are doing this, I think it's to have recognized the general practitioners, then how we are functioning, and they should be, if we are filling the B12, there should be a process for the compensation, because sometimes we have to travel, like we have to see the dead body and take times, right? And it had happened to me about like 10-15 years back. I was called and then I went there, confirmed the death, and I cannot charge them, right? I know it's not only the like, you know, money is not the thing, but when you are doing it properly, there should be a compensation. So I think that there should be a way of doing that.
Actually, we fully agree with you, but as per the Act, it is a voluntary thing. But when you go for quality and considering the time efforts taken, there should be a compensation. We are going to recommend that. Let us do first the basic and preparatory things with all the formats updated, and then to go for a change amendment to the Act.
Is there any question from online virtual platform? I can see none. Anything else? Yeah.
This is okay. I'm registering and general practice.
Yes.
Just want to ask one question. Like last week, I had to do a home visit to confirm the date of the patient. And so I basically did, what I did was, I wrote in my letter the identification and also the fact that I had confirmed it, and also the conditions that patient was suffering with. And I signed and put my seal and gave it to the family.
Mm-hmm.
So I didn't use any form as such, either B12 or B33. I just want to know whether that is good enough for, you know, in that situation.
Yes, I think until we get the V12, we have to go as we practiced. So when the B12, now we are awaiting the great B12 to come. So because I'm very much into that, because now you cannot provide proper palliative care without this form. This is my opinion, because at the because now we are running few hospices. Practically what is happening, patient with multiple diagnoses, and we are treating them, we are taking care of them as a terminal ill patient, but when the patients are grasping, we have to send them to the nearby hospital, because we don't have this death certification, proper death certification form. Otherwise, we have to call the Grama Niladhari, the doctor will confirm the death, and the Grama Niladhari comes and give the death certification. So that is why I was telling, if we want to, you know, establish proper palliative care, the terminal care in this country, this this is very, very, very important. And Madam took it very seriously. That is why she gave her leadership, and now we can wait only we will wait 2 months. Then with the B12, so your question also, I think we can solve. And the medical practitioner, I think it's access registered medical practitioner. Even Ayurvedic registered cannot, no? Only we can. Allopathy. Under section 29. Okay. So then we can do, so still it's an honorary thing, but Madam will recommend for a compensation also. So any other questions?
Yeah, one more please.
Last one, yes.
Yeah, I'm asking this from sir. There are deaths that we have to attend to, like very old people, patients, like people who are dying at home without any medical conditions, like they are bedridden and they just die. So in that case, how do you give the cause of death, like, you know?
Yeah, this is a common question asked by, especially by general practitioners. We don't advise you to write senility or old age as the cause of death. So you have to try your best to find out any pathology or any past medical history, or maybe the history of immediately what has happened to the patient, whether he complained of chest pain or whatever it is, to give the cause of death. Failing all these, advisable thing is to do an autopsy, because but it is not possible all the time. So sometimes we may have to write old age or due to senile debility or whatever it is, but it is not a good cause of death. If the patient dies in a hospital, it should not be given as old age. Maybe it will go for an autopsy. At home deaths, you will have some social pressures also when you want to send the patient body to the hospital to do an autopsy. But that is the correct practice if you cannot give the cause of death. So that depends on the circumstance. So try to avoid as much as possible to not to give the cause of death as senility or old age.
Okay, thank you so much. I think now it's time to wind up. So let me thank, on behalf of College of Palliative Medicine of Sri Lanka, so let me thank Dr. Lakshmi Somatunga, our Additional Secretary, Public Health Services, Ministry of Health, and our immediate past President of the college. Madam, thank you so much for arranging and helping to do this webinar on April webinar, and Dr. Saman Gamage, and our council member, Dr. Rangana Vadugedara, for having this important webinar today. And thank you so much, all the participants, physically and virtually, who participated, who joined with us. And I'm sure this knowledge will enhance the uplift, the proper good cause of death certification, and it will improve the quality of Sri Lankan medical practice as well. Thank you so much.
Very short invitation. There was a representation by the College of General Practitioners, and we like to extend our collaboration beyond the College of Palliative Medicine, and also to the College of General Practitioners, and we like to move forward and to continue this conversation in future. And there's ample of resources produced already, handbook, online application, and also offline tool also there, and we have a good group of resource persons 2 already identified from the NIHS, and at each and every province we have consultant committee physicians trained on this, and you can always contact our College of Palliative Medicine and also my unit if you have any queries or further assistance, and we are very happy to extend this technical assistance towards capacity building of general practitioners in Sri Lanka. Thank you very much.